72-year-old female presented to the clinic with complaint of feeling unwell and confused. Cousin reports patient had been moderately confused. Patient described sudden fatigue, decreased appetite, decreased fluid intake, confusion, urinary incontinence since the previous day. Medical history of hypertension, type 2 diabetes, controlled by diet, cholecystectomy, up to date on flu and COVID vaccines. Family history included cardiovascular and cancer-related conditions. During the physical exam, patient had a temp of 100.2, heart rate of 122, and high blood pressure 178/90. She appeared unwell and confused, but maintained good eye contact and clear speech. Lab results showed high glucose levels of 224, and a urinalysis indicating hematuria, leukocytes, and moderate ketones. Primary diagnosis was urosepsis, supported by systemic symptoms, fever, tachycardia, and altered mental status, and positive UA. Delirium was considered as a secondary diagnosis due to fluctuating confusion. Pyelonephritis was considered but refuted due to the absence of key findings like CVA tenderness, flank pain, and no history of recurrent UTIs. Patient recommended for immediate transfer to ED for further eval, including CBC, CMP, lactic acid, CRP, blood cultures, UA with culture insensitivity. Treatment involved antipyretics, IV fluids, IV antibiotics, pain meds, antihypertensive medications, and medications to address her elevated glucose. Differential diagnosis included urosepsis as the primary diagnosis, while the secondary or comorbid diagnosis included UTI, uncontrolled hypertension, elevated glucose levels. In summary, the primary diagnosis was urosepsis supported by clinical findings. However, further eval in the ED is essential to assess organ function and confirm diagnosis. Delirium is also considered due to patient's altered mental status. Pyelonephritis remained a possibility if clinical findings change. Close monitoring and additional tests are crucial for effective management. Uncertainties regarding this case were the patient's unknown urinary output. Assessing urine area output is critical in evaluating sepsis and kidney function. Patient's refusal to disclose sexual history due to altered mental status raises concerns about possibly sexually transmitted infection as an underlying cause. Alternative approaches included exploring systemic infections conditions regarding the patient's age and comorbidities. Management plan prioritized prompt eval and treatment of urosepsis while addressing associated symptoms. I would also emphasize patient education and follow-up. One learning issue was assessing and managing altered mental status in older adults. Questions for preceptor: given the patient's altered mental status and confusion, how should we proceed in obtaining a thorough sexual history, considering the possibility of STIs as a contributing factor? Self-directed learning questions included best practices for communicating with older patients and with altered mental status and optimizing delirium management in the adult primary care setting.